The recording will be posted on the advisory committee's webpage shortly after the meeting. For everyone's reference, today's agenda can be found under the first tab in the materials. Welcome, advisory committee members. It is now 2:04 and I call the March 7th joint meeting of the advisory committee on data issues and the advisory committee on healthcare providers and carriers to order. My name is Rochelle Bogue. I am the Cost and Transparency Manager, and I would like to give a warm welcome to everyone joining us today. I look forward to engaging with each of you in this exciting work. If you guys can all turn to the agenda, we will start with a brief overview of the agenda. First, we'll begin with roll call, then we will approve minutes. Next, we will hear public comments. After public comments, Evan Klein from the Healthcare Authority will provide us with some legislative updates. Following that, Liz and Gary from Health Management Associates will lead us through the Cost Board's 2024 work plan. And finally, Sherielle Nomingit from Healthcare Authority will give us an overview of the 2024 data call. We will then wrap up and adjourn today's meeting. I encourage committee members to ask questions and provide feedback to help facilitate our discussion and recommendations to the board. Thank you all again for your time and efforts and your participation today. Now we'll go through member roll call. I will call members by first name in the order listed on the agenda, which is in alphabetical order by last name. But I would also like to use this opportunity to allow members to get to know each other more. So when I call on you, please unmute your microphone to let us know that you're here. And then let us know what you are looking forward to most this spring. And then please mute your microphone again. We will start the roll call for the Advisory Committee on Data Issues. Krista.
Good afternoon, everybody. Krista Abel. I have a new grandson, so I'm looking forward to spending time with him.
Oh, how cute. How old is your grandson?
He's 2.5 months old.
How adorable.
Thank you.
Thank you, Krista. Megan. Megan. Amanda.
Hi, good morning, Amanda Avalos. One of the things I am looking forward to in spring is starting my vegetable garden.
Oh, that's nice. Thanks, Amanda. Jonathan. Jonathan. Bruce. Do we have Bruce with us? Jason.
Morning, everyone. What I'm looking forward to is trying to tame my backyard as much as possible.
That's a good goal. Thank you, Jason. Chandra.
Hi, what I'm looking forward to is completing our garage remodel this spring.
That's a good goal too. Thank you, Chandra. Leah.
Sorry about that. Got to find the mute button. I'm here and I am definitely looking forward to Tulip Festival.
Oh, I'm looking forward to that too. Do you go to the Tulip Festival in, where is that, Skagit Valley?
In Skagit Valley, we try to, yes.
Fun. Thank you. Li Chao. Okay, David.
Yes, good afternoon. I'm also looking forward to gardening.
Got a lot of gardeners here. That's great. Thank you, David. Anna.
Hi, I'm here. Hi, everyone. I'm looking forward to drier weather. I'm in SoCal, and we've had so much rain, and I'm so done with it.
That's funny. You're in California, and you're looking forward to drier weather.
Yes, I know.
Thank you, Anna. Hunter. Do we have Hunter with us today? Mark.
Present. Hello, everyone. Looking forward to the time change and longer days, hours of daylight.
Yes, that does sound nice. Thank you, Mark. Russ.
Hi, I'm here this afternoon, and yes, similar to Mark, I'm looking forward to longer days and warmer weather.
Thank you. Mandy?
Hi, I'm Mandy Starr, OFM. Well, I still have snow up here because I'm up at around 700 feet. So I'm kind of looking forward to the snow all melting.
Yeah, I would be looking forward to the snow melting too. Hopefully it's soon, Mandy. Thank you. Julie? Do we have Julie with us today? Okay, now I'll turn to the Advisory Committee of Healthcare Providers and Carriers. Bob? Justin?
Hi, yeah, this is Justin Evander. I'm here. Looking forward to, we got a family reunion / spring break trip going down to Arizona to get some sun.
That's nice. Thank you, Justin. Paul? Paul with us today? Jody?
Hi, this is Jody. We're looking forward to the same doe who's had twin fawns on our lawn the last 5 years, coming back and doing that again. So it always brings joy to our.
Cute. That sounds nice. Thank you, Jody. Luis?
Hi, I am looking forward to having a fracture that I incurred hiking the 2nd of February heal, so I can travel again. I had to unfortunately cancel a trip to New Zealand and Australia, and I am waiting to get out of my walking boot and back onto a plane.
Oh, I'm so sorry to hear that. Hopefully you get your trip to Australia and New Zealand rescheduled soon.
Definitely next year. Absolutely. Yep.
Thank you. Stacy? Ross? Eric? We have Eric with us. And we just found out that Todd will no longer be a member of the committee. So I'll move on to Vicky. Natalia?
I'm here and I am looking forward to slightly warmer weather in the morning to walk the dog. I mean, I am bundling up with all of my stuff and it is still cold. So looking forward to some warmer weather and definitely the brighter light.
Yeah, I'm sensing a theme here. We're all looking forward to that. Thank you. Jeb? Do we have Jeb with us today? Okay, Dan? Dorothy?
Hi, everyone. I'm here and I'm looking forward to heading down to the Texas area to see the eclipse in April.
Oh, that sounds fun. Oh, and it looks like Jeb just joined us. So I will go back to Jeb. We are letting everyone know what our favorite or what we are looking forward to most for spring. Jeb, if you want to say something.
Hi, sorry, having technical issues. Jeb Shepard, Washington State Medical Association. I like cooking and I can't wait to cook outside when the weather gets nicer.
That sounds nice. Thank you, Jeb. And I think we left off with Wes.
Hi, good afternoon. Wes Waters from Lena Healthcare. Looking forward to spending time with my wife, working in the yard and just doing some things around the house and spending time together. And I did put a message in the chat box. I do have to leave after the first hour. My apologies to the group.
Okay, thank you, Wes, for letting us know. And thank you for letting us know what you're looking forward to most in spring.
This is Chris Abel. Julie Sylvester is all on the call as well on a telephone call. She's on 206-384-6701. So she tried to talk but can't.
Oh, okay.
hear.
Yeah, we will have to convert her to a panelist. You get the- Oh,
Yeah.
I'm sorry. We aren't able to convert somebody on the phone to a panelist. Oh, but we can unmute her so she can speak.
Hi, yes, I'm unmuted. This is Julie. Do you hear me?
Yes, we can hear you.
Great. I'm just 10 minutes away from my computer for Zoom. I'm just running between meetings. I'm looking forward the most to having my son be done with the college selection process and the whole application and where we're going and all of that.
That sounds nice. Thank you for sharing and thank you for joining us until you're able to get to a computer. Appreciate it. And that's the end of the roll call. Please join me now in turning to tab 2 to review the meeting summary. We will approve the meeting summary now from the January 18th meeting. As a note, the recording of the last meeting is posted on our webpage for reference. We will use the consensus process for a vote on approval of the meeting summary since January 18th was a joint committee meeting. Is there any discussion of January 18, 2024 meeting summary or proposed changes? Is there a motion to approve the minutes?
This is Russ. I'll make a motion to approve the minutes.
Thank you, Russ. Is there a second?
This is Leah. I'll second.
Thank you. All in favor, say aye.
Aye. Aye.
Aye.
Aye.
Okay. I'm sorry, Eric Lewis just raised his hand. We just want to make sure that he has an opportunity to speak if he was trying to say something.
Hello, sorry to be late. I
Oh,
voted
no
yes.
worries. Thank you for joining us, Eric. I wasn't sure if you had anything to say regarding the meeting summary, so I wanted to make sure we gave you an opportunity.
No, it looked good. It
Okay.
looked good. I just couldn't say anything. Now I'm a panelist or something. Thanks.
Well, now that you're joining us, we were saying what we are looking forward to the most in spring. If you want to share what you're looking forward to the most.
I like the light. I just like it being evenings going longer. So I get off work and I feel like I have time and energy to do things.
Yeah, that was the theme. I think we're all looking forward to longer days, not being in darkness anymore. Thank you, Eric, for joining us. Okay, we will go back to the meeting summary. We had a motion to approve and a second. All in favor, say aye.
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 And any opposed? Okay, motion approved. The meeting summary.
Just a quick note, this is Jody. I'm abstaining because I was not at that meeting. Thank you.
I'm sorry, Jody, what was that?
I'm abstaining because I was not at that meeting.
Oh, okay. Thank you for clarifying, Jody. Appreciate that. Okay, the meeting summary is approved. Next, I would like to welcome any public comments. The third tab in the committee book contains information related to public comments. If you would like to provide public comment, please raise your hand. Then we will call on you after we hear from individuals who have signed up. When you are called upon, you will be invited to join the meeting as a panelist. To ensure speaking, please join the meeting as a panelist and unmute yourself. Please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. Please remember that this is the time for public comments. Any other sessions during this meeting are times for the advisory committee members only to ask questions and discuss. Mandy, I'll hand it over to you now to facilitate public comments.
Thank you. I didn't have anybody sign up in advance of the meeting. I'll turn it over to see if there's anybody who would like to raise their hands for public comments, and I'll monitor that. So far, I don't see any hands raised. But if you would- Give it another minute for public comments to see if anybody would like to raise their hands to provide public comments. I still don't see any hands raised. Thank you. Next, I will turn it over to Evan Klein, Special Assistant for Policy and Legislative Affairs here at the Healthcare Authority, so he can provide us a legislative update. Welcome, Evan.
Hey, good afternoon. Can everybody hear me okay?
Yeah, we can hear you, Evan.
Perfect. Well, happy sine die. The legislative update is the legislature is going to adjourn sometime today, and we're all going to be excited about that as they make their way out of Olympia. So I wish I could end there. We are obviously in the midst of wrapping up the short 2024 legislative session. I was brought here to give you a little sense of what actions the legislature took over the past 2+ months. As mentioned, I'm Evan Klein. I'm the Special Assistant for Legislative and Policy Affairs here at the Healthcare Authority and manage our agency's legislative relations. We have been really busy, as we usually are during this past session, working with the legislature on a number of agency-led priorities, as well as engaging on a number of priorities kind of more directed by the legislature. I'm not going to touch everything because there is a lot, and we're really in the process today and into next week of digesting everything that the legislature is sending our way from bills passed and the conference budget, which was just produced yesterday. But I will hit some of the highlights and then save a little bit of time for questions. So please feel free to raise your hand or stop me throughout if you have a question about anything I'm touching on. I don't have presentation materials because we really are just in the process of digesting everything this week. But happy to follow up with you kind of through Mandy and team if you have any questions about anything that came out of session in the weeks to come. So first, the biggest bill kind of impacting the cost board directly was House Bill 1508. And this bill actually makes a couple of changes to the cost board's advisory committee structure and directs some new work of the cost board. The bill was initially dropped and worked last legislative session and has shifted quite a bit over time. But where it landed, it changes the stakeholder advisory committee, so not the data advisory committee of the cost board, but changes the composition of that committee to bring in some voices from consumers, employers, and labor into that committee structure. The bill will also direct a annual hearing process for entities that are subject to the cost growth benchmark under the board, and directs 2 new studies. So there's a new study coming to the cost board around underinsurance and a new study around cost trends in the employer and employee space that the cost board will be directed to do. Both those are on a biennial cadence, so not every year. But that's work that the cost board will start picking up kind of over the next couple of years with a report due to the legislature. I believe the first report on each of those is due in 2026. So that bill has passed the legislature. We expect it to get signed by the governor's office, and we expect those changes to get implemented over the next couple of months. We also expect some new funding that is going to come with that in the conference budget for some staff support with the agency that we are excited about, including some staff support with our data team in addition to the cost board team. So we'll be unpacking that here as we kind of dive deeper into the budget, but just wanted to flag that off the bat. Louise, it looks like you have a question.
Yes, thank you. So when I looked at the bill, it seems that stakeholder committee is a new name for the advisory committee. And so does the membership continue and then new members are added for the new designated spots, or do you start with new appointments all over again?
I think the former, and I would look really to the cost board team on specifics there, and it may take a little bit of time to provide you some certainty, but I don't think that the legislation itself contemplated revisiting the entire membership of the advisory committee, but is really looking at adding a couple of new seats to that committee.
Thank you.
Yeah, of course. So that's obviously, you know, the biggest bill directly impacting the cost board and the cost board's work coming from this past session. But there's a lot that was also moving in the cost space. There was a bill being led by the Office of the Insurance Commissioner around ground ambulance balance billing and prohibitions on balance billing of consumers for ground ambulance services that we expect to get passed and signed into law by the governor. There was legislation this session, I believe it's Senate Bill 5213, that is changing some of the regulatory structure for pharmacy benefit managers in the state, including a prohibition on spread pricing, something that we have implemented across our state purchase programs, and the state is looking to mirror across the fully insured commercial insurance market here in Washington. There were a couple of bills that also failed this session, but engaged the legislature in some robust debate in the cost space, including the Keep Our Care Act, which is 5241, that did not inevitably pass both chambers, but engaged the legislature in a lot of conversation about regulation of mergers and acquisitions of large health systems in the state. That was a bill being led by the Attorney General's office, but one that we were closely tracking here at the Healthcare Authority. And we know a number of our sister agency partners were also engaged on. And then the Health Benefit Exchange had a bill looking to standardize the individual market as well, that inevitably failed to pass both chambers, but again, kind of engaged the legislature in a lot of debate around how to structure the health plan offerings on the individual market and kind of curate that plan shopping experience and make sure that plan offerings are providing value to those consumers. So we expect some of those policies are likely to come back in future legislative sessions and likely to kind of engage us in some interim work. But kind of a couple of things floating in the cost space kind of directly. A number of other bills on the periphery as well that I would just flag that had impacts to cost. We know there were bills around coverage of PEP and coverage of EpiPens and inhalers, or epinephrine auto-injectors and inhalers, looking at kind of cost sharing restrictions on those. So ensuring that there's $0 PEP offered by commercial insurance plans and reduced cost sharing, low copays for epinephrine and for inhalers. So kind of legislators who are looking at some of the out-of-pocket cost impacts of your health insurance benefit for specific highly utilized drugs and treatments, and thinking about how the legislature can be involved in capping those out-of-pocket costs. So we expect some of those bills to pass and get signed into law this year as well. And beyond that, I think, a number of bills focused on, expansion of coverage, new benefits, kind of floating around that space that were debated this session, many of which didn't make it across the finish line in a short session, especially, larger policy initiatives. But some kind of concepts we expect to come back in future years, such as benefit mandates for cancer treatments, biomarker testing, some of these other kind of advanced therapies. We saw a lot of conversation with the legislature this session about those policies, which, I think the legislature is often approaching those topics from a constituent mindset, people who are trying to gain access to treatments. And we're thinking about that as juxtaposed to some of the cost conversations as well. How does that impact the cost of our programs, on the front end, cost for purchasing and paying for new services, but also on the back end, potentially, if it's decreasing the morbidity of an individual or ensuring our populations are healthier, et cetera. We recognize there are those other impacts as well. So just things that we're conscious of as an agency and that we expect to track into future legislation. Beyond that, in the budget, like I mentioned, there are a couple of items funded for the cost board, which we're excited about. We have been talking about continually growing the staff support for this work so that we can grow in our capacity as an agency. And we're excited to see some investments from the legislature in the conference budget there. We also saw some additional investments in other programs, which are broadening access and also may have some impacts on overall costs for our delivery system. Something that we're excited about as an agency, the legislature invested over $20 million of additional funds in what we're kind of calling our Apple Health Expansion Program. So this is, you may have heard of this, it's our we were directed a couple of years ago by the legislature to expand Medicaid to immigrants who lacked access to Medicaid or subsidies through the exchange, and directed us to create a new Medicaid-like program for those individuals. So it's generally adults up to 138% of the federal poverty level. And that program is set to go live July 1st of this year. So we already had program funding for that from last legislative session, but the legislature increased the investment, which means we are going to be able to increase the caseloads for that program. So we're still unpacking a lot of the details, but excited to see some of that funding in the budget. We know that the legislature is investing some money and creating some new financial programs for graduate medical education in the budget, looking to pull down Medicaid dollars for investments there. There was a lot of funding for our Medicaid transformation project, our 1115 transformation waiver through the Medicaid program that we had requested, and we're excited to see in the final budget from the legislature. And then funding to support various services across our portfolios. So, tribal pharmacy encounter rates, behavioral health investments, looking at further investments in analyzing comparison rates for our behavioral health delivery system to determine whether what we're paying providers is adequate. Investments in community health workers, investments in health homes for kids. So a lot of, kind of smaller line items, but across various programs in our agency budget that will impact the Healthcare Authority, impact our Medicaid program, and impact, the behavioral health delivery system. And then I'll also just note kind of on the PEB-SEB side, so impacting our employer and retiree benefits. There was direction in the budget for the agency to study consolidation of the PEB and SEB programs. So there will be some work done by our IRB team over the next year plus to kind of review what consolidation of that those programs might look like, and some specific direction in the budget from the legislature on what information they're looking for kind of in that space around costs and benefits of that type of work. So I'm going to pause there. Happy to take any questions or if there's any curiosities from you all. Otherwise, as I said, still unpacking a lot of this, so may not have all of the details today. But to the extent you have any questions, we could certainly follow up with you offline if we can't answer today. Cool. Well, you should have my contact information. You can obviously reach out through Mandy and through the cost board team if there's anything that you are curious about over the next couple weeks or months. We're happy to be accessible. And as we kind of unpack all this, I'm sure there will be some opportunities to come back before the advisory committee or back before the cost board and talk about some of the additional work that we got from this legislative session. But as the legislature is promptly doing behind the scenes right now, will wrap up and give you some time back. And appreciate you giving me the opportunity to come today. So thanks.
Thank you, Evan, for those updates. Next, I would like to welcome and introduce Liz and Gary from Health Management Associates, also referred to as HMA. HMA is working with HCA to provide subject matter expertise, facilitation, and strategic planning to support the work of the Health Care Cost Transparency Board. They will give us an overview of the outcomes that came out of the cost board retreat on February 9th and the policy recommendations the board has selected to focus their efforts on for 2024. And they will help facilitate discussion of these policies so all our committee members have an opportunity to weigh in. Welcome, Liz and Gary.
Thanks so much, Rochelle. Hi, everybody. It's good to be with you. I see some familiar names, so it's exciting to be part of the great work you've been doing for the last couple of years. So, as Rochelle mentioned, my name is Liz Argent. I'm from HMA. I am based in Seattle. Have been working in Seattle in health policy and health program initiatives for about 20 years, on and off. So, very familiar with the importance of this work to our state and happy to be a part of it. I'm going to just set the stage a little bit here about the meeting that we had with the cost board in February, and then hand it over to Gary to get more in depth on the policies and where we're going from here. So can we go to the next slide? That would be great. Go ahead. Keep going. Thanks. So at the February meeting, the retreat, there was a real focus of the board to start moving in the direction of becoming actively engaged in how they might take a role in addressing healthcare costs. There's been data that you all have been receiving, considering over the last time period. And there's a real interest now in turning to what can the board can the board do about this? And so HMA, along with HCA, worked together to pull together a list of several policies for the board to consider that they would decide to spend their time on throughout 2024, looking at and thinking about, is this something that we might want to do in our state? What does the data tell us? Is this important? And we grouped the policies in a number of ways, targeted to broad, from short-term to medium, and varying degrees of impacts. And we also touched on whether or not there was an active effort underway in the state that was associated with that particular policy. And as Evan just mentioned, there was a lot of activity going on during the session, so things were very fluid at the time. So we can go to the next slide. At the retreat, we also had the chance to hear from Jane Beyer from the Office of the Insurance Commissioner about an affordability study that they are in the middle of doing right now. They've completed a phase 1 of this report, and it includes several in-depth analysis and description of several of these policies. And a second part of that report is going to be coming out in July this summer, and will focus on including actuarial and economic analysis of some of these policies. We also heard from the Attorney General about their affordability preliminary report that is connected to the work that the OIC is doing. And then finally, the board also heard from managers from several states doing similar work with cost boards across the country, including Massachusetts, Oregon, and Rhode Island. And so all of that was really a backdrop and foundational as they then looked at the policies that they might want to spend their time on. And so I'm going to hand it over to Gary, and he's going to talk a little bit about those policies and where we're going from here.
Thanks, Liz. And it's very nice to be with all of you and be involved in this work. Just briefly by way of introduction, I'm a principal at HMA. I've been with the company for 2 years, based in San Francisco, as you can probably tell from my background there. Before that, for 5 years, I was head of government affairs for Blue Shield of California. And before that, I served in the Obama administration at CSIO, working on implementation of the ACA, initially as head of the oversight group, and then as director of CSIO from 2012 through the end of the first open enrollment period in 2014. So we, as Liz mentioned, we tried to group these various policies in a variety of different ways, what impact they would have, whether they were the effort to implement them would be a short-term or medium-term or long-term effort to try to gauge, the difficulty of implementing these policies. And then to what extent there are other agencies in the state that are looking at some of these same policies to try to make sure that we are complementing but not duplicating effort that was happening elsewhere. And the board heard a description of the various policies and in summary what they are meant to do, and also got some, as Liz mentioned, some specific examples of how these policies have been implemented in other states. The next slide, please. So the board was asked to prioritize which policies they would like to focus on during 2024 to identify recommendations that they will make to the legislature, and with a goal of trying to choose not only long-term policies or not only policies that are the hardest to implement, but kind of a range of policies, which they did. And then in the course of the discussion, it was clear that just because certain policies were selected to be prioritized for this year does not mean that other policies will not be taken up by the board at some future time. Next slide, please. So after discussion and votes that are reflected here on this slide, the policies that were selected, you can see here, provider rate setting and price growth caps was the one that got the most support. Limiting hospital facility fees, then addressing mergers and acquisitions, private equity, and broadly speaking, the question of ownership of healthcare facilities was the next, and then restricting anti-competitive clauses in healthcare contracting. Receiving fewer votes were two sort of transparency policies, one increasing hospital price transparency and one increasing community benefit transparency. Next slide, please. So the policies that were not chosen to be addressed or reflected here, I won't read through all of it, but you can see what those are. I would say that in many cases, this looks to be more of a reflection of the issue of what policies are being addressed elsewhere in the state, rather than some feeling on the part of the board that these policies are not worth pursuing or not worth doing. Next slide, please. So one of the things that, I'm first of all happy to answer any questions about what these policies are, what the board heard about, what the different policies entail. But what would be extremely helpful for the board, for these committees, would be to identify data resources that would help provide insights, would help evaluate these various policies in terms of what benefit they would provide, how they could be implemented, et cetera. And from these resources, what specific information would be helpful in that effort. And I think that's all we have. Yes. So again, we're happy to answer any questions or engage in any conversation, and look forward to hearing from you all in terms of, with your expertise on to help educate the board and help it with its work.
Hey, Natalia has her hand raised.
Thank you. Just wondering, you mentioned you'd be willing to give a little bit of an overview. Curious on this first one here that received 9 votes. If you could say a little bit about what that policy, what that would entail, or maybe a summary of it.
Sure. So, essentially, obviously the board is tasked with the responsibility of setting cost growth benchmarks for the state. And the question, and there are a number of states now across the country that have boards that are doing similar work. The question then arises, well, how are we going to accomplish meeting those targets? And among the ways to try to meet those targets would be to directly address prices charged by providers in one of a variety of different ways. One way would be some kind of rate setting process where the state would establish rates for services through a process that would look, like rate setting in other contexts, public utilities, for example. And another would be a cap on price growth that would be enforceable, which obviously is not currently, the board does not currently have that authority.
Krista Abel has her hand raised.
Yeah, thank you very much. So I might be off track on this response. I'm kind of newer to the committee, but I'm going to go ahead and just kind of say what's on my mind. So when I joined the committee, we were there was a cost growth driver study that was shared with us. It was an Amy Kinner, I think, from On Point Health Data. And the data that was shared, it was quite extensive. There was a lot of work. This was a group that was working for the Healthcare Transparency Advisory Board. And essentially, as I drilled into the data and reviewed it, because I was very interested in understanding what the cost drivers were. And as you looked at the information that was provided, it was about utilization. It was about extensive utilization. There was no information that was specific to hospitals that was combined. There was inpatient data, outpatient data. It did show extensive increases in outpatient data. It was essentially because of the transition from inpatient to outpatient, but that in a nutshell, the conclusion that I drew from that study was that between 2018 and 2021, the increase in cost and spend was not a negotiated spend issue where you have mergers and acquisitions and anti-competitive clauses that are causing this. It was utilization increases. And in fact, if you drill into that data, when they separated out the allowed amounts increases versus utilization, I think it was about 2% on average per year. And so I am baffled by why, and how do we know that these things that are being discussed that would impact, some of the larger groups. I'm part of Virginia Mason Franciscan Health, but do we know that these are going to support reductions in the healthcare cost in the industry, or are these just the same old talking points that have been used by health plans in Washington State for the last several years? Because I don't personally, I've been involved in contracting for years, and I'm not familiar with anti-competitive clauses that we've implemented that have increased spend. And as far as the mergers and acquisitions, most of those mergers and acquisitions occurred because the hospitals had to join larger systems in order to survive. So the only reason I'm saying this is because I feel like we're heading in a direction that it is intended to reduce costs. And it's not necessarily going to produce that effect, since the analysis that was just provided to this group indicated that it wasn't an issue related to commercial negotiations and hospital negotiating commercial spend. The commercial spend in our market is about 25% of what's negotiated by hospital industries. So I feel a misalignment, and I just feel like I need to go on just to express that. And as far as the data resources for any of these kind of issues or concerns, I think there needs to be more information about what is it that is driving these conclusions, that these are the areas that should be focused on. And I might be missing something. Maybe my perspective in our organization, that hasn't been the case, and I'm missing something, but I would just like to better understand where is the basis or evidence that these are the things that have been driving the healthcare spend in our industry. And I'm going to just throw in one more thing, since I'm on a roll here. it's really difficult for me to listen to this. And these are the focus areas at a time when most of the hospital systems in our state have been losing millions and millions of dollars, are in a very difficult situation. And yet the inflation situation that hospitals are experiencing aren't even discussed. They are not even on the agenda. So I feel like there's an agenda that's moving forward, and it doesn't matter really what hospitals may think. It's going to go in that direction, and there's nothing that we can say or do that's going to change it.
So I think I'm hearing two different things that I think I can respond to. One is the question of, does the data that we have support moving in the direction of the policies that the board identified as its priorities for this year or not? And I think that's a conversation that, has to happen and will continue, moving forward. And, whatever thoughts you have on the data or additional data that we need or that the board needs would be welcome. I think the second thing that I'm hearing is that there's an area that affects the total healthcare spend in the state that relates more to delivery system reform than it does to price. And the interplay, obviously, cost is a function of, utilization and price, as Jody put into the chat. If we believe that the prices that are being charged for services are part of the reason why costs are where they are and growing, as well as utilization. And then the question of utilization raises, are we talking about services that are unnecessary services? Are we talking about expensive services that are being provided where, maybe not be really what's needed by the patient? I mean, it's, so there's a whole area of delivery system issues, I think, that may be beyond the scope of what the Transparency Board is tasked with doing.
Yeah, I guess there would be three things. Is that on-point study, what is being done to address the actual issues that were provided to this Transparency Board about what's driving cost? Because it wasn't hospital negotiations. And secondly, why aren't we talking about those things? Yeah, the utilization and the kind of issues that we're seeing as part of that study. And then third, what is the evidence that these things are happening? Because as somebody that's been involved in the hospital industry, I'm not familiar with inappropriate language and that kind of thing. And so maybe I'm missing something, but it would sure be helpful if these are the areas that are being focused on, to know for sure that these are actually things that are happening and that are actually driving costs. As opposed to, again, I feel like this state has general talking points that have been going on for years that are talked about in the different conferences and whatever, but I just don't see it as I'm on the inside looking out, and maybe I'm missing something.
I see a number of other hands raised. So Leah, your hand is up.
Hi, thanks. Sorry, I don't have reference to the slide. Just to Julie's point, I guess I would say I don't know that everyone would agree with the conclusion that the primary reason was utilization for cost increases. At least that's not my take, especially when combined with the other analysis you shared and that we've heard about from other sources. But to answer your question, when looking, just a clarification or maybe a question back to the board to consider is, I'm not sure that they were looking at these policies in order to decide that they wanted to adopt them, which many of which might be outside their authority, but to use some of their analysis to drive further into Washington's experience to help inform a potential recommendation to
Yes.
others. Is that okay? So that I think is helpful and maybe comes a little bit back to Julie's point too of where could we recommend that they lean into the data in Washington state to, you know, be a little bit more specific in our state on some of these issues. And I think we have many of those pieces here when you put up the, I call it the crayon
Yes.
chart. But one I'm not sure about is the community benefit. And not saying that that isn't a good area to look into, but I don't see anything in the kind of current analysis and authority that would help with that. We have the hospital cost, profit, and price analysis, which maybe some of that would include where community benefit is being spent. So that was just be an observation that they might have to add an analysis in order to really help inform that. And I believe a lot of that work happens over at DOH, so maybe it's a collaboration with them. And then I do think maybe mapping some of those policies to the analytics support initiative that the UW is helping with, because it feels like there's a lot of alignment there that we should be able to, now that we have some potential questions, policy questions, we should be able to see how many of those pieces, and it might be somewhat in that third kind of possible analysis. That's the drill down. So just thinking a little bit more, I haven't given thought to it, but thinking a little bit more about that is where my mind was going in terms of what might be most informative. But I feel like, you know, we got version 1 on the cost driver analysis and cost experience, the latest report from Vishal. And I think that's going to be another key piece of it. So it'd be interesting here to see some of the how the analysis is laying out over this year. Maybe we could help inform the board through that process of where we see the analysis that might most closely tie to their policy question, their chosen policy question, and where we would encourage them to, you know, to lean into that reporting before finalizing. And then I do think, to your point, Liz, the additional reports that OIC and the Attorney General's office are doing, you know, are great work. And I know they'll be wrapping up for phase 2 this summer, I think. So probably those are other components that aren't the board, but will be important to consider.
Thank you, Leah. I think, can I ask our HCA colleagues to put that crayon thing back up? Because that is exactly the question that we're really looking for feedback on, is how do you see the work that's already been identified and underway, that the cost board is doing, the data work? How do you see that being informative and helpful to the policies that, as you clarified, that are just being investigated over the course of the next year? There, again, there's no decision to move forward on these policies. It's just, these were the ones that the cost board said, you know, we think that this is something worth looking at. And so we'd really love your thoughts on how the crayons on the right-hand side do or do not support the information that would be necessary in investigating these selected policies. And if you have additional sources of data, that we'd love to hear about it. So I think I see Eric's hand too.
Yeah. The only other thing, I think the mergers and acquisitions is, I mean, that's what the AGO's office is working on. And I don't see a lot of analysis here yet that would help inform that. So those are just 2 gaps that they might need different data sources for.
This is Eric Lewis. Do you want me to go ahead?
Yeah.
Yeah, I'm the CFO at WISH, Washington State Hospital Association. And I was just wondering about, one of the items is limiting facility fees. And what does that entail as far as off-campus or on-campus physician clinics or ancillary services? What that means? I'm not not exactly sure what limiting facility fees, because
Well,
facility
I mean,
fee.
I don't think the board has gotten to the point of being more specific in terms of the exact policy that, or, you know, recommendation of policy that it might in the future after studying this and reviewing it. The issue, as I think you are aware, you know, has become a pretty significant issue across the country in situations where additional fees are charged in contexts where a hospital, for example, owns an outpatient practice and a fee is charged, whereas it would not be charged if it were an independent practice that was not owned by a hospital. I mean, that's very broadly, bluntly, you know, framing the issue. But how exactly those that issue would be addressed, or could be addressed, let's put it that way, is the work that has to happen, you know, going forward. If any such policy, if the board ends up deciding to make any sort of recommendation with respect to that issue, the specifics of that would have to be determined going forward.
Yeah, I think the key piece of data you need when you look at limiting facility fees is what is going to be the impact on access for Medicare, Medicaid, and other patients. Because I think oftentimes by significantly cutting reimbursement, you're going to reduce access to services that patients really need. And if you look at, I think that, you know, the reason there are facility fees is because hospitals, you know, are open 24/7. Regulatory requirements are much higher, and they certainly treat a lot of Medicare, Medicaid, and uninsured patients. And I think there's been some studies that hospital-based facilities and clinics treat sicker, older, poorer patients. So I think looking at the Medicaid population and seeing how facility fees, if you cut out facility fees, how are you going to impact access? Because I think that would be a serious concern, and it may have unintended negative consequences as far as costs. You know, rather than somebody going to a primary care clinic, they wind up going to an emergency department, which is not going to save money in the long run.
Julie, I see your hand up.
Yes, I just want to say, you know, I want to step back. I've been in healthcare for a long time, like many of us on this call. In the title of this, you know, was cost, right? And these issues underneath this policy, these aren't cost drivers. Facility fees aren't cost drivers. Facility fees are generated when a patient receives a service in a facility-based hospital. Price growth caps and provider rate setting, those aren't drivers of cost. Drivers of cost are labor. You know, I would think anybody on this call who runs or works in a hospital would say 50-60% of their costs are labor. Drivers of cost are drugs, buying drugs, acquiring drugs, supplies. Drivers of costs are the hoops and administrative costs that systems have to incur to process a claim or get a utilization. So I guess I want to just step, you know, I mean, it's great to say, boy, we want a target of 3.2% and we're gonna, you know, but there are there are drivers that are causing that. Do we say then, hey, nurses, hey, techs, we can't go through with your labor increases, your wage increases this year because we're outside of the 3.2%. Those are the drivers that systems are being impacted. But this stuff that you're showing right here, these aren't the drivers.
I mean, I think most economists would say that price is a driver of cost.
I would say price that is reflective of utilization and cost.
Okay. Thank you. Dorothy?
Yeah, thank you. I would remind everybody, like Julie just did, and to really think about what we mean by cost versus, how that relates to rate setting and to the price growth caps. One thing that really strikes me about this, which might be helpful in terms of additional data, is that there's been a tremendous amount of work in the state of Maryland, which gets beyond, it feels like this work is taking the state of Washington kind of a little bit backwards. We've done so much work in the state about, well, yes, it's rate setting, but it's also looking at how that connects with access and quality and what are we getting for the money. And I'm just a little concerned that if we focus on these fees again, we're going to be way back into fee-for-service land, as opposed to, the progress, for example, that the state of Maryland has made in terms of moving from that into more looking at population-based global caps, that kind of thing. So my question is just more of a comment that this feels stagnant to me in some ways in terms of where the state of Washington is and has been. And some of the analysis, even from some of the state agencies, I think of the Washington Health Alliance, I think of the BRE Collaborative, all of these places where people have embedded into contract some of the ways that you can actually decrease costs. And it's just a concern, and I'm a consumer rep on this for right now, that as a consumer, I would be very worried that all of this is related to something that doesn't really relate at the end of the day to Washington population having a better experience for the dollars that are spent. So just a little bit of trepidation about this feeling to me to be not where this group left off even a year ago in terms of all the investments that have been made in behavioral health and housing and all of those things that actually help impact the cost. And I don't see that on here anywhere. And I'm kind of concerned about that relative to where the state actually is. I'm not saying these aren't good things. It's just, it seems sort of predictable.
Thank you, Dorothy. And I think, raising Maryland and the global budgeting system that Maryland has put in place is something that is discussed in the report that we did for the OIC and was discussed at the Transparency Board meeting. I don't think that not having this on that list is not a reflection of that global budgeting is not a worthwhile policy to think about, but more that it was something that is being looked at and addressed elsewhere in the state, and a desire not to duplicate that effort. At least that's kind of the interpretation that I would make.
Yeah, that was one of the policies that was identified as being looked at in the OIC in a much longer term. I think also some of these were selected in some ways because they're thinking they're things they could do sooner rather than later. And mainly to address, like the facility fee one is something that they're hearing a lot about from the consumer side of things. So.
Thanks.
Jeb?
Yeah, thanks, Gary and Liz, for the presentation. Really appreciate many of the comments that have been made today. And I just would like to make sort of a big picture sort of request, and that's that when you're looking at these policies and sort of analyzing them, health policy is a series really of unsavory trade-offs. And as Eric mentioned, we can't just be looking at like the dollars saved. I think we also need to look at some of maybe the more unsavory trade-offs, like the quality and access to care. As Eric mentioned, we've had an awful time with labor and delivery in rural areas, for example, which is just one prime example of services that would be that would feel the squeeze. So all that's to say, when you're doing an analysis, I would implore the board and HMA to look at all the outcomes, not just the cost of care. Thank you.
Thank you, Jeb. I thought I had seen one other hand, but I'm not seeing it anymore.
It was mine, Gary. It's Krista Abel.
Oh,
So I just wanted to emphasize that as far as the data resource, I just want to say it is, to me, the data resource is that On Point Health Data Study that was provided back in February 2023. And just questioning whether these things are going to impact the actual spend based on that study. Secondly, as far as the anti-competitive clauses in healthcare contracting, I'd be curious to know what they are, to actually see what language that this is talking about, because I don't understand what this is. And then the mergers and acquisitions, it'd be nice to actually update it, to see that actually, evidence that the mergers and acquisitions is even an issue in Washington State, since the majority of the mergers and acquisitions are already occurred. I mean, how many hospitals are left that's going to impact this category? Is like, what is the value of focusing on this if we don't have evidence that it is an issue, and if there's not an opportunity in the future, because it's kind of water under the bridge now. Limiting facility fees, I think I do know what that is. I think some hospitals charge for facility fees, but I think this is so minimal. I don't think it's a major portion of hospital spend at all that it'd have any major impact, or maybe it's not worth the time to focus on that, but I don't know that for sure. And I guess the one thing that's missing here is I feel like there's a whole other side of this that maybe it's not on the hospital side, that there's transparency with health plans and how health plans are setting premiums, and the whole benefit factor that it may be impacting utilization and some other things that are not these focus areas.
So I can respond a little bit. Krista, so on the anti-competitive clauses, I have to confess I'm a lot more familiar with this issue as it has impacted California rather than Washington. So I don't take my comments to indicate that the same thing that happened in California is happening in Washington, because I can't say that. But you may be familiar with the litigation that the Attorney General in California brought against Sutter.
Yes, I am familiar with it. Yes.
Okay, so there were a number of clauses in, the one example being, if you wanted a Sutter hospital to be in your network, you had to take all the Sutter hospitals.
Yes.
Right. So that's an example of what was felt, at least by the Attorney General in California, to be an anti-competitive clause.
Yeah, do we know that is happening in our state, though?
So that's a fair question. That's a fair question. In terms of the mergers and acquisitions, I think you're right that there's been consolidation has been happening, in lots of parts of the country, including in Washington, both vertical and horizontal. One of the challenges that we faced when we were retained by the Office of the Insurance Commissioner to do this study, and the legislature specifically asked for information about this subject, is how hard it is to get information about who owns what in the healthcare field. We were literally, looking at websites and making telephone calls, and there's really a lack of, particularly in the private equity area. It is not simple to get information on the ownership structure of healthcare facilities. Very different when it comes to health plans, for example, which file with the Office of the Insurance Commissioner, and they have to, tell you, who their subsidiaries are and so forth. So that was part of the issue that was discussed by the board at the retreat, was, just what can we do to get more information about the ownership structure of the healthcare system in Washington. In terms of the impact of this, I'm not familiar with any particular study that calls out Washington State specifically to look at what the impact of this consolidation has been, but there are many, many, many studies that show that, generally speaking, the more consolidation there is, prices go up and quality suffers. So that is the background for this issue. And, what the impact of that is, and what the state can do at this point, given the current, as you have rightly said, the current situation, which is not going to be unwound, are all questions that I think the board and these committees need to discuss going forward.
Okay, well, thank you for that attachment. That somebody included the checks. I haven't seen that. Leah.
Jonathan has a hand raised.
Yeah, hey, thank you. So Jonathan Bennett from the Washington State Hospital Association. Appreciate your time and presentation. I echo a lot with what's been already said today, but additional context and kind of framing of this I think would be helpful. As others have mentioned, the evidence kind of behind driving these pieces is also important from a context standpoint. We do have feedback that we'd like to share on these, and I was just wondering if we could also follow up through a letter or email afterwards, if that was a possibility.
We'd be happy to hear anything you have to offer. Absolutely.
And then I would just also echo what's already been said about kind of the unintended consequences. I mean, that's such a key piece as we look at these things, as we strive for certain directions. What are the unintended consequences? And others have really mentioned them. I mean, obviously access is the key and a big piece that we want to make sure that we're focusing on. Labor costs impacting the workforce obviously is a big driver here. I mean, we've struggled over the last several years to get the personnel to be able to provide the care here in the state. And then obviously, I think quality is a big piece. So appreciate your time. But again, we're requesting more kind of context and framing of this just so we can provide better feedback and input on this. So we'll be following up through email or through a letter. So appreciate your time.
Right. And I just want to say it would be really helpful, especially for WISHA, because I know Gary and I had the chance to talk with some of your folks in the fall when we were doing the work for the OIC, and we know you have a wealth of data. And I think what we really, really, really need from folks is, are these data sources on the right going to be able to support an investigation of these policies in the way that you all are requesting for, so that the board has wanted to settle on these policies? What we really need is help from you all as experts. What data exists that can help evaluate these? So thank you. Jody.
Yeah, thank you. I just want to make an observation. I think if we reflect on the last half hour, 45 minutes of conversation, I think it helps illustrate why the legislature just changed the membership of this group to enhance the consumers of healthcare in the state of Washington. I think this conversation for the last 30 to 45 minutes is really centered on us as providers of care, as leaders of healthcare organizations, as those who are negotiating prices, who are setting prices, who are determining insurance coverage for our own systems. And as a CEO of a community health center here in Whatcom County, but also as a recent cancer patient, the conversation that we've had over the last 45 minutes has resonated a lot more with me being a CEO of a healthcare organization than it has with me being a recipient of care and of needing to navigate unbelievable prices and pharmaceutical costs in the reality of day-to-day healthcare in the state of Washington. And so I applaud the wisdom of our legislators. I don't think we always see that, but I think we do here, and how they enhance the proposed membership of this group. And I think that all of us need to remember that we occupy multiple seats simultaneously, and that we need to think about that when we worry about access, we have to worry about access not only for the folks that we hope come to our places, but the people whose lives we're responsible for, either as employees or as neighbors or as other residents of the state. And so I think we need to have a more balanced conversation. We all worry about costs, we all worry about prices, we all worry about utilization. At the end of the day, it is the average citizen in the state of Washington whose wages are not increasing at the rate that the cost and the price of healthcare they're being confronted with is escalating. And so that's where I think we need to channel, lean into, embrace, and work together on.
Thank you, Jody. Any other comments?
I don't see any other hands raised.
If not, Rochelle, I'll hand it back to you.
Okay, yeah, I don't see any other hands raised. Thank you, Gary. Thank you, Liz, for the presentation, and thank you to all the members for your questions and comments and participating in that discussion. It's great to see the board develop their policy priorities for 2024. And I know we all look forward to the board's continuous efforts to help reduce healthcare costs and increase price transparency for all Washingtonians. Next, we'll hear from Sheriel Nomingit, Health Economics Research Manager here at the Healthcare Authority. She will provide us with an update and overview of the 2024 data call. Welcome, Sheriel.
Good afternoon, everyone. This is Cheryl Namingit. I joined the cost board staff at HCA in January, and I will be providing an update of the timeline for our for this year's data call. So as some of you heard or are aware, we launched a second data call that will be collecting 2020 to 2022 data. This will be added to the historical or baseline data that we collected in 2022, which were years 2017 to 2019. We have sent the letters to carriers, and the deadline for submission is on May 15. So once we start receiving the data from carriers, we will conduct the data validation, expecting to be done by July. And after that, we will start conducting our analysis, and then we hope to generate carrier and provider reports from August to October. We will share these reports to providers and gather feedback. After incorporating feedbacks, we will provide the final report or the preliminary report to the board by November to December. End of this year, and hopefully we'll be able to conclude the data call process by the end of this year. And that's all on the timeline for the data call 2024. Are there any questions on the timeline? Jeb?
Hi, sorry if I missed this. I had to step out really quickly. Have you all done any outreach yet to the provider groups that are subject to the benchmark? And if not, when might they expect some dialogue around this?
Yes, may I defer to Mandy to discuss the timeline for this provider outreach?
Sorry, Jeb, your question about the preliminary provider reports that we have talked about with you?
Yes.
We're thinking within the next couple of months, we'll have old data. Now, just as a reminder for folks, that is not public reports. That is data from non-public information that we received in the last data call. And so it is a sort of sample report that we're providing to providers based off the data that we received from 2017 to 2019. It's not a benchmark data. It is just preliminary data that we're using to help providers become familiar with the provider reporting process. And we anticipate having those out to providers within the next couple of months.
Thank you.
Thank you.
I don't see any other questions or hands raised. Cheryl?
If there is none, then I will turn over to you, Rochelle. Thank you, everyone.
Thank you, Cheryl. And that brings us to the end of our meeting today. The recording and summary of this meeting will be posted shortly on our website. Thank you again to our presenters. Our next meeting will be held on Wednesday, May 29th, and that is when we will be able to formally welcome our new committee chairs, Bianca Frogner and Eileen Cody. And thank you to all our committee members for participating today.
Thank you.
Thank you. We look forward to seeing you at the next meeting.